Hello, welcome to Medical Update. I'm your host, Dr. Mike Rosen. The Hofstra North Shore-LIJ School of Medicine is New York's first new allopathic medical school created since 1963, making it the country's 133rd medical school. But this new and non-traditional med school promises to be very different in how medicine will be taught to this new breed of physicians starting in August 2011. Our guests today are responsible for shaking up the existing medical education curriculum. Dr. Lawrence Smith is the Dean of the Hofstra North Shore-LIJ School of Medicine, and he is also the Chief Medical Officer of the North Shore-LIJ Health System. With him is Dr. David Battinelli, the Senior Associate Dean of the Hofstra North Shore-LIJ School of Medicine, and he is also the Health System's Chief Academic Officer. Gentlemen, welcome to Medical Update. This is a big deal, no?
It certainly is.
You must be very excited.
Every day. Every day we're excited and terrified.
That's very honest. Why are you doing this? I mean, this hasn't been done since 1963.
So I think there's a couple of reasons. One is the imperative to train American students for American healthcare. It's clear that over the time since the late 60s, really, until the current time, we haven't expanded medical schools to meet our population's needs, and we now import a very large percentage of our doctors from abroad because we're not training people.
Especially in this area,
Absolutely.
in the New York area.
Yes, and the sad thing is that we have many qualified students who could be physicians who can't find places in medical school. So that's kind of the national imperative. But there's a local imperative, which is that the North Shore-LIJ Health System is one of the largest health systems in the country that doesn't have its own medical school and is the primary teaching site of a school. And Hofstra University, I believe, really had almost simultaneously come to a level of maturity where it was ready to be the university of a medical school. And so this was kind of a marriage made in two institutions reaching maturity at the same time, a need in this area and a need nationally.
You're co-owning, this health system is co-owning this medical school. I mean, is this a reasonable business decision for the health system?
I think it's very clear. This is the ability to become and brand the North Shore-LIJ Health System and Hofstra the University with the medical school brings enormous benefits to both institutions. To Hofstra, we really boost the science programs, the pre-medical programs, and an influx of scientists into a growing scientific community at Hofstra. On the health system side, this really brings you into, sort of the elite club of medical schools. There's only 133 medical schools. We've had relationships with many medical institutions over the years. We have over 100 residency training programs. We have 1,500 physicians in training in terms of their specialty and subspecialty training, and the opportunity to be our own medical school and change the way that we, in fact, train doctors to be is an enormous advantage.
Are you looking at this as sort of a feeder system from sort of ground level where you're going to have these medical students who are then maybe going to go through your graduate medical education through residency programs and then maybe be physicians actually on staff of North Shore? Is that part of the plan?
Yeah. Well, clearly that's a potential that there will be students. But if you think about the size of the health system and then the size of the school, we're starting with 40 students. We will eventually have a class of 100 students. So we'll only graduate 100 students per year. We have many, many, many hundreds of recently graduated students entering residency programs in the health system and have many, many hundreds to thousands of physicians. But I think it's a little bit more than that. That's a perfect opportunity for us. But these students will be graduating and heading into residency programs all around the country and perhaps coming back eventually to work in the health system in areas that we need. But it helps us redefine how we do education. It's been a fascinating process all through the institution with the multidisciplinary involvement of all the physicians thinking about what is the best way to educate physicians. It really changes the way that we approach patient care and education.
So what's going to be the same and what's going to be different about this medical school that's going to make it perhaps special?
So I think we started off with, the core competencies that make for a physician ending their medical school phase and about to start their residency phase or training. And it's clear that there's a set of competencies that every medical school accepts their graduates should have. I think the difference is, how do you get them there? And how do you solidify the learning so that it really is lifelong and not just temporary? And so we made a few decisions right off the bat. One was that we always knew that doctors remember things best that are wrapped around real patients. And you know, you can remember things from the classroom to pass the test.
Always.
But the things that you had to learn in the care of a patient, you never forget. And so why not do that from the beginning?
You can't remember a disease, but once you see one patient with a disease,
right,
and you read about it, you know it.
Absolutely. So one of our mantras was, this is all about knowledge and action. It's not about passing a multiple choice test. It's about, can you take the science that's taught and see it in the patient and use it in the patient? Can you remember things forever and not just to pass a test? Because this is no longer a student game. This is about preparing a caregiver for life. And so we made a few decisions. One was, everything we teach would be wrapped around real patients.
From first
right
year
from day
on?
one. Yes.
Day one.
Day one.
That's very untraditional.
Absolutely. And the second core principle was that our assessment would test knowledge and action, not just memory of knowledge. And maybe you can pick up on
So
that.
to that end, we're not going to have traditional multiple choice questions in the school. I mean, that's not the way, you know, a good doctor isn't somebody who knows the answer to a multiple choice question. It's somebody who's able to apply knowledge and action. So we will ask them to express in essay form their understanding of concepts, behavioral sciences, basic sciences, the care of a patient. And we will also watch them in a special center that we've built, the Patient Safety Institute, that houses simulators, standardized patient rooms, etc. So we will be able to see how they do and sequentially test them, assess them, and coach them. We talk about sort of 20% assessment, 80% coaching to move them to where they need to be. They're smart enough. They've passed the sort of pre-medical hurdle. Now we're going to make them into doctors.
So for the folks out there who haven't been doctors or medical students, traditionally, people go to medical school, they're sitting in a classroom for the first, in most cases, 2 years. Some schools have just 1 year, then they go into the clinical realm. But what you're basically saying is, from the get-go, they're learning about the physiology of the heart and the anatomy of the leg with a real person in front of them.
Absolutely. And the courses are integrated so that they're going to learn health and disease together.
But how do you do that? I mean, are you doing it in the hospital?
So let's talk about some of the crazy ideas that, because we were starting from scratch and no one was pushing back, we were allowed to live out our fantasies, so to speak, and build a curriculum that we really thought was cutting edge. So buried in the first 9 weeks of the medical school will be the organizing principles for the whole teaching of the first 2 years of medical school. And in that, we're going to cover the EMT curriculum and actually have them take the licensing exam in New York State to become licensed EMTs and immediately begin working in the ambulance system that the health system owns, seeing patients out in the community.
How
with a
exciting
real
for the
skill set.
student.
Yes.
That's great stuff.
Paired with that, they'll be in small groups, dissecting cases, trying to figure out what the learning objectives are, teaching each other, being assessed with essays. In the mornings and in the afternoons, be in doctors' offices, taking care of patients right from the early days of med school, so that before the first year of med school is over, they will have delivered a baby, taken care of pregnancy from, you know, the beginning till the delivery. They'll have participated in surgical procedures and operations, taken care of elder patients in their homes. And what it really highlights is the resource. You can sort of see that we've got a terrific campus on Hofstra University, a phenomenal new building, and a resource within the health system in terms of our assessment facilities and this vast number of hospitals that the health system operates, to be able to have the clinical faculty to be able to provide things that other places we've been to just couldn't provide before.
You have thrown the traditional model truly out the window. I mean, almost completely.
Preserving, I think, the best of the core values. But yes, we have said we're going to teach in a whole different way.
This isn't unlike, though, people who are trained to become physician's assistants. They often get thrown into the clinical realm a lot earlier, and they function just fine. So this isn't a willy-nilly concept.
Right. In fact, we could always get Dave started on his analogies of what this is about, but if you think about it, if medicine is knowledge in action to produce effective outcomes, and it's really not just about being smart and answering questions on a test, then you have to practice that. Because knowledge in action, you can't just learn by sitting longer and longer and longer in a lecture hall. At some point, you have to practice it to get good at it. And, you know, the analogy Dave uses all the time is Little League Baseball. You know, 9-year-olds start off completely discombobulated. They can't even throw straight. You know, if they hit the ball, it's by accident. They wouldn't learn to be able to play in the Little League World Series only 4 years later if all they did was sit in a room and have somebody lecture them on how to swing a bat. And so we don't intend to lecture people at how to practice medicine. We want them to practice it. And we will give them a core skill set. We will be there to support them. And we'll wrap their learning around real patients and teach them how to learn in that setting, and then push them out the door and say, go.
We have about 30 seconds. How is this being received by the applicants out there?
It's tremendous. We've got, you know, thousands of applicants, again, for only 40 positions the first year. But it's interesting because all the schools around the country want to do similar things to what we're doing. It's very difficult for them to reform themselves in as dramatic a fashion. So the things that the students are hearing about at other places, we've actually sort of taken to the next level. So they're all for this. These are new millennial learners. They're not going to sit still. They want to know, why aren't we always learning the science and the clinical care together? And that's what we're going to do.
This is incredibly exciting stuff, and congratulations and good luck with this.